Hey, hello. Good night, everybody. I hope that everything is having a very good Saturday. So we're going to start now. So before we start with the forum and while we are waiting for everybody to join us, I'm going to do a very brief introduction about the study group. But first of all, thank you everybody for joining this fourth discussion forum. Um, okay, so I'm going to start doing the introduction. So we are Qhali Peru, a study group in dental public health. Our mission is to promote the specialty of dental public health among undergraduate and graduate dentistry students from Peru, as well as to contribute to the development of their skills as researchers in this area, to generate spaces for scientific dissemination, and in a long term to propose interventions to improve the oral health and reduce inequities. Our vision is to be a solid group with members from all Peruvian regions and dental public health researchers from different parts of the world who collaborate with each other for their development as researchers and to generate or improve oral health interventions among the Peruvian population. So one of the main activities of our study groups are these discussion forums. The aim is to increase the knowledge of basic dental public health concepts and awareness of the existence of this discipline among undergraduate and graduate dentistry students from Peru. For this year, we organized 6 discussion forums. So in May, we have this discussion forum with Diego. Then in June, we have another with Ananes. In July, with Abdul. And now we will have our fourth discussion forum about challenges in health promotion and prevention of oral diseases with Julie Farmer. So these are some memories about our previous discussion forums. We had a very good opportunity to discuss important topics in this area. And we also created some summaries about the discussions forums in a form of these infographics that we shared on our social medias. So now we will have this forum about this important topic, and I am very happy to have Julie with us. Also, the group that already did this post for our social media related with the topic of this forum. So if you didn't review it before, please go to our Instagram account and review this post that is very interesting. Okay, so now I'm going to introduce our discussion forum coordinator. She is Melissa Salazar. She's an undergraduate dental student from the Universidad Científica del Sur. She is also a member of the International Association of Dental Research, and her research interests are about global health and oral health intervention. So thank you, Melissa, for organizing this forum, and welcome to this.
Thank you, Dr. Camila. And well, now we are going to have a presentation about Dr. Julie. And so she's practicing dental hygienist, and also she is a PhD candidate at the University of Toronto. Her thesis topic for Master Science was comparing income-related oral health inequalities between Canada and the United States. And her PhD thesis topic is exploring characteristics and healthcare utilization patterns of children with early childhood caries. And about the research areas of interest are dental public health, professional issues in dentistry, oral health inequalities, health services and policy, and finally her website. And well, if you prefer to follow her, is juliewfarmer.ca.
Thank you, Melissa, and hello, everyone. It's nice to see everyone here, and I'm excited to chat and discuss.
Thank you, Dr. Julie. So now here are some research, some articles that we about the forum. And well, thank you another for being here, Dr. Julie, with us. And we are so excited about this forum. And well, before we continue to the forum, please, if you could take some words about the forum.
Sure. So I wanted to just say thank you, everyone who submitted questions from these 4 papers. I think a lot of the questions will cover some of the main issues that were presented in these papers. But in general, you know, this topic on challenges in health promotion and disease prevention, what these papers represent are some challenges with identifying what population should be targeted for disease prevention and health promotion. So that's that Rose paper. And then looking at the interventions that may be used to improve population health, oral health, or prevent disease. The Laurent, the paper on the bottom, kind of gives us a good sense that not all interventions are equal and will lead to equal outcomes or positive outcomes. And really there's a big emphasis, I think, in all 4 papers that targeting behaviors may actually worsen inequalities, so lead to bigger gaps between the rich and the poor. And then we move on to the other 2 papers, common risk factor approach, and then integrating the common risk factor approach, the second paper. So that one, I think there is a nice question coming up that kind of explains more or looks more into what is the common risk factor approach, how might it be implemented, and what does it really mean for oral health professionals. So the top paper, common risk factor approach, is a nice introduction. And then the second paper kind of revisits it and looks into, okay, what do we do with the common risk factor approach and how do we implement it so that we are preventing, we are reducing inequalities instead of making bigger gaps between populations. So that's my brief. Yeah.
Thank you. Thank you, Dr. So we are going to pass now with the questions. And well, the first topic, we divided into, I think, 4 topics. And the first one is the common risk factor approach. And the question is, what is the common risk factor approach for oral health promotion?
Sure. And I think this is a really good question because it gives us an opportunity to provide a nice introduction to the common risk factor approach. So if we think of oral health, there are many different risks for oral disease. And when we want to promote oral health, we address those risk factors. So some of the risk factors in the paper that was provided in the reading is, you know, how diet can impact your risk for dental caries or dental cavities, how stress can increase your risk of periodontal disease, how different things like smoking, alcohol, those can impact your risk of oral cancer or periodontal disease. But with a common risk factor approach, what that gives us an opportunity to understand that those risk factors are also risk factors for other diseases. So diet, that can increase the risk of obesity, heart disease, diabetes, alcohol, risk factor for heart disease, again, just as an example. So the common risk factor approach is telling us that if we address a risk factor, diet, we're actually helping prevent many different diseases or reduce the negative impact of those diseases. So I hope that is clear, but I'm happy to expand on it. So with the question of what is the common risk factor approach, sorry, for oral health promotion, really it's health promotion that includes oral health promotion. So you're addressing diet, and it could be interventions that reduce consumption of sugar. Well, that's going to promote or decrease the risk of diabetes. It's going to decrease the risk of dental cavities and decrease the risk of obesity. So there's an example for you. Happy to continue on this discussion, or if anyone has any points or thoughts on this, feel free to put in the comments or unmute as well.
Yeah, well, for me it was really clear, but anyone here have a question about, or could have an example?
I have only a comment, like, I really like this approach because I also like to that provide us the opportunity to work in a multidisciplinary way, right? Because when we think about any oral health intervention, will be very important to integrate other health professionals from other disciplines to create, elaborate, or develop these type of interventions. Like, because yeah, and going back to that previous forum where Abdul was talking about the link between oral health and systemic conditions, so that relates a lot with what we are talking now. So yeah, it's a very good point of starting this forum. So yeah, I really
Yeah,
like.
it's a nice connection between the two.
Yeah,
I think it's also good that you highlighted that, because as clinicians, like when we're dentists or dental hygienists, in our operatory, we're thinking, how do I prevent, how do I improve my patient's oral health, or how do I prevent their disease? But at the same time, going outside of the office and talking with another healthcare professional and kind of collaborating with them to improve their overall health. That's one thing.
yeah.
I think we're going to get to other questions about where to intervene, but yeah.
Yeah, so yeah, so I only want to emphasize that if everyone would like to add anything else, please feel free to open your microphone or write it in the chat. Okay, so let's move to the next question.
Well, now we have the next topic, and it's high risk and population approach. And the first question about this topic is, what are the potential drawbacks of focusing on high risk and vulnerable population in population prevention?
Okay. In the way, so I wanted to emphasize something. My responses are my opinions and views, but people might have different views of it as well. So I'm just happy to share with you what I think based on the readings and what I've experienced. So just letting you know. So my interpretation of this question is maybe someone asking, why shouldn't we use a high risk approach to population prevention? What might be a negative thing that happens if we go that route? What might be an unintended consequence? So from what I'm thinking, with a high risk approach, well, if you're doing a high risk approach, you have to identify the population that's high risk. So one of the questions is, how do you actually make that decision? Who's going to be in your high risk intervention or program or whatever you're planning, or policy? So, and that's kind of discussed in the first paper, the Rose paper. So one of the issues is, are you just making these made up cutoffs in terms of income? I think people who make income less than 30,000 Canadian dollars a year are eligible for this program because they're high risk. Well, what does it mean for someone who makes $32,000, right? So you might be missing people based on this high risk approach. The other one, and I'm going to use the other thought I have, and I'm going to use the example of high risk being, people who are low income, who can't afford dental care. With a high risk approach, you're identifying people who may be eligible for your program based on their financial means, based on their ability to afford care. So you have a program targeted at people who can't afford care. Well, imagine you're the potential person who's eligible for the program, and now you have to declare to someone, I can't afford to access dental care, therefore I would like to be part of this program. You can imagine like the dignity and how it could be humiliating in a way if you're that person who has to then go and access this program. So thinking about how you're planning that program may have a negative consequence. A person may feel stigmatized, and it may just be a negative experience for them. The other thing with a targeted approach, a potential drawback, is now you've got this defined program for a group of low income individuals, or whoever you want to, whoever you're targeting. And then they're stuck in that program, and their access to care is then is limited to what that program offers sometimes. So they might not get the care that they need, because maybe that program doesn't cover the services that they need. So another potential limitation. Those are my thoughts. I'm happy to think of other ways to answer this question, or if someone has other comments, or maybe how the papers define high risk or vulnerable. Maybe people have comments on that or thoughts on that too.
Yeah, I remember that I read that also in the high risk approach, because also it depends on the definition of high risk. No, when a patient is on high risk, and sometimes when we identify this high risk of the patient that is clinical related, we could be victim blaming. We could stay in this victim blaming thing that and yeah, that part I found very interesting. So can you talk a little bit about this victim blaming? What does it mean? um how it's related with this high risk approach?
Sure, I can do maybe briefly. So yeah, I have to think about that. So in terms of victim blaming, just would it be like creating a negative experience and with the dental care? Like, maybe I don't know how to answer this.
Yeah, but it's, for example, when we say that a person is high risk because they this
Oh, they're
person
doing
eats a lot of
something wrong.
sugar.
Yeah, I get what. Yeah.
Yeah,
So you're.
yeah, for example, because of that, this behavior that a person has, but maybe this person eats a lot of sugar because it's the only food that they have available on the place where they are living. Yeah, it's a way to blame the victim, who at the end is suffering for these social determinants of health. But yeah, not sure. Yeah, and I think that thinking about how
And
to identify these high risk people, maybe it's not the best way to create these interventions, but also has some pros. Yeah, but yeah, it's complicated sometimes.
Melissa, did you have a comment?
well, yeah, I'm not sure. And how do you identify like the people that eat a lot of sugar, or how do you identify that population, right? For example,
Yeah.
here in Peru, yeah, we don't have any financial aid for healthcare, especially the dental care. So, yeah.
Yeah, I guess it goes into what the intervention would be, and then how you would
Mhm.
apply it to that population. So I think it would be choosing the right way to choosing the right risk factor. You might have like a proxy, like this is represented by low income, or some characteristic you can define. The people who might go to a diabetes healthcare center, they're high risk for periodontal disease, so you can consider that high risk in that way. But nothing's perfect, right? Because not everyone who has diabetes might go to that center, so you're missing out on those people. So there's a lot of potential to miss people who would benefit from it, but at the same time you're doing something for people who are at high risk. So especially in the context that there's not a lot of money to do things, so sometimes you have to apply to a smaller population, so you're planning for people who would truly benefit from your understanding of disease and things like that.
Okay, I understand.
That's my thought, but maybe someone has other thoughts as well.
So anyone here have another question? I don't know. We can pass to the second one, I think. Yeah. Okay, so the second one is, how can population-based prevention be effective in improving population health and reducing health disparities?
Yeah, for this one, I thought maybe it would be good to go through a brief example of maybe what might be a population-based prevention. I'm going to try and go with just water fluoridation, because I think that is something we're all familiar with, and it applies to the whole population, right? So maybe that's too simple. So population-based prevention essentially means that it's applying, you're doing something to, sorry, Carla, you are unmuted. Maybe she's accidental unmute. Okay. Feel free to comment if you want to unmute again or something. So water fluoridation, it's population-based because everyone in the community who has access to water is going to, or tap water in this sense, because that's usually how it's introduced, is receiving that intervention. So therefore, so they're receiving that intervention, which means they're getting the benefit of fluoride for caries prevention. So what you would see is overall the prevalence of dental cavities would reduce in that population, because everyone is now receiving water fluoridation. So you would expect children in the community to have a lower rate of dental caries over time. And then it would hopefully reduce disparities if everyone has, is consuming water equally in a way. But then it's tough to really isolate or specify that this intervention is going to improve population health and reduce disparities, because there's so many behaviors and things going on in people's lives that will change their risk. But in general, you should see a decline or an increase in population health by measuring a decline in dental caries and hoping that that decrease is equal across different populations. Let's say low income, high income, or rural versus urban, depending on how wide it reaches. Any comments? Welcome.
Yeah.
Is there water fluoridation in Peru? No. Can anyone think of maybe an intervention that might be applicable to?
I think that we have fluoride on the salt. But I have an issue with fluoridated salt, because the salt consumption increase blood pressure. So I don't like when people want to add fluoride to some food that is not healthy. And do you know what? Sometimes, and that is something that freaks me out, like someday as a population-based strategy to prevent dental caries, people wanted to add fluoride to the sugar.
So that's interesting, because what that would just, I don't know what that would do.
That was crazy.
Increase and decrease.
I don't know, but yeah, we don't have water fluoridation because we had at one moment, but then I think that it was very difficult to maintain it or something like that, and to control the amount of fluoride. And also because not everybody have equal access to water. But I'm not sure if it's correct, potable water, like clean water. So that was another issue. But yeah.
Yeah,
I'm sorry. Yeah. In Canada, every do you know the percentage of how many people? I know that most of the people have access to clean water, but maybe there are some group of people who may not have this access, right?
yeah. So it also depends, and I think that is the question 3 too. It also depends on kind of the local context. Like, is it going to work in that community? And not everywhere is fluoridated. But I was thinking of another example for number 2 might be maybe relevant, is like tax on sugar sweetened beverages, because that applies to everyone. All the beverages that are sweetened with sugar are going to be taxed. So anyone who purchases that that beverage is going to have to pay a tax, which might disincentivize them to buy it because they don't want to pay more than what they're used to. So hopefully that reduces their sugar consumption, and then hopefully that will then lead to reduced cavities or caries. Do you use caries or cavities? I don't know. Both?
Caries.
Caries? Okay.
Caries.
So reduce their caries. And so hopefully at a population level, again, there's a reduction in caries. In terms of health disparities, though, that might not occur because people might opt to choose a different beverage, or maybe higher income people are willing to spend that money, or lower income people are willing to spend that money. Like, it's not for certain that a reduction in an improvement in population health means a reduction in disparities. It's tricky, but hopefully that's an example, and we can build on it.
Thank you. So now we are in the 3rd question, and it's how can population preventive strategies be implemented in different cultural and geographic contexts to address social inequalities in health? We already talked about, but we can.
Yeah, and what I was thinking when I read this is some work that like I'm currently kind of doing, but I don't know fully about, is just thinking about transferring good strategies that work in one population, how that can work in another population. So there's a really nice framework. It's called, I will type it in the chat so that everyone can Google it later. Consolidated framework for implementation research. Has anyone heard of it before? If not, it's okay, because I'm more recently heard of it. But one of the things that's nice is it borrows from the field of implementation science. So when you want to implement something in a community or whatever environment, it gives you a framework to kind of think about what kind of contexts, or how might different contexts or environments impact your implementation of it. So it lets you think through why something might work or might not work, or what might need to change in order for it to work in your community or population. So that's my way of answering. This is like, use a framework and kind of get thinking about how a certain strategy can be implemented in different contexts, because it's really tricky, and like not everyone no, I don't think anyone really knows how to really do it well. So it's a whole science.
Yeah, I know. But that's a great answer. Yeah. So
I'm sorry.
no,
Well,
it's okay.
I'm not sure if it's a question or comment. Well, but do you think that there is another approach that is called the community-based participatory research approach? Is this could be related to this implementation science in a way of considering also the opinion or perspective of the community before implementing something, right?
Yes, yes. And that was something I was thinking of bringing up later.
Okay.
But no, it's good to bring, who cares? We can bring it up now. It's okay. It's just, whatever population or group you're going to implement or be part of, it's good to collaborate and partner with people who know the community well and have them involved instead of just informed. So instead of just telling them, we're doing this for you, it's going to be great, just work with them. We're doing this. Is this going to work? What might be some issues we have to think about? Who can we contact? And like really get your hands dirty and work with them and share the planning with them. But it's a very good point. And maybe this is the next question, so it's good. What I was thinking too is that third paper, the common risk factor approach, table 2 of it, there's a table, I don't think we have to go to it, but if you go to that third paper in table 2, which is a few pages down, it lists all the different players or different people who should be involved in implementing a policy or a strategy. So it's a nice reminder that if you're considering implementing something, to brainstorm about who should you be contacting, and who can you get involved, because maybe they have an interest in the topic and they might be able to support it, or maybe they want to conflict with it. So making sure you have buy-in and support from everyone, or you can compromise with them. That I think that's important to consider for question 4. It's really tough to answer specifically how can you implement a strategy for low income or this, but I think in general, if you know which population or group or community you want to implement, then trying to find people you can connect with will help make sure it works, hopefully.
I'm not sure the PDF only, maybe to remember where it is.
Sure.
Yeah.
It's the number 3 is the, I don't know what the page is.
Can you see my screen?
Yes.
Yep.
Is this one?
Yeah. So what I like is the columns, there's the producers, the processors, manufacturers, caterers. These are all people who are involved in policy around food. So they have an interest in what's going on in that world. But you can think of what I like about it is just highlighting people other than us as the dental care professionals. It's people outside of the healthcare environment. So not other, doctors or nurses, it's people in social environment or in the industry. So it's something I like to just remind myself, okay, if I'm doing this, I should see how they can be involved or what they're doing, or maybe advocate. So recommend that they change something in what they're doing. And that's a way of addressing, that's some type of intervention.
Okay, so this is from this paper only, to remember people.
Yes. Yeah. And it was written 23 years ago, but I think it's still very relevant.
Yeah.
A lot of good ideas in there.
Yeah.
And people still use it, so that's good.
Yeah, the other day I was talking with you about the importance of these frameworks and figures and tables that are in the papers. These tables and figures talks more than all the paper.
Yeah, yeah. It's true. You find really good papers and they're timeless. Like they apply basically all the time. But frameworks, I really like frameworks, and I find whenever I'm doing something, I try to find a framework to help give me steps of what to consider. So
Yeah. So okay, so
Well,
really,
yeah, I think we answered the fourth question. Yeah. It's fine. So, well, the final question is, how can population-based prevention strategies be adapted to address the needs of vulnerable populations such as low-income people, elderly people, and people with disabilities?
yeah, I think some of the comments I made for the other question apply to this one, like identifying people who know that population well, and partnering with them. I don't know if I have specifics for like each population group. So it's kind of like a general question. Maybe some of you, based on your experiences, you have thoughts on, you know, who should you contact for low income people or elderly people, or people like who should be on board. Maybe if you're doing an intervention, you want to do something for people with disabilities, who might be people you want to partner with or reach out to. You can write in English or Spanish in the chat if you want, and we can kind of think of it together. Or if time, we can move on, whatever is up to everyone.
I only wanted to say something because I forgot when we have the first question about the word vulnerable. Yeah, because uh, now it's like saying vulnerable is not a correct way to call this group of people because it's also increased like inequities. So um, I shared this PDF like any time ago, but I'm going to share it again in the chat soon. But instead of saying vulnerable, we have to say, for example, people who live in vulnerable conditions created by the system or by the government, or communities who are made vulnerable by the government, the system, or vulnerability created by systems of oppression. So these are better ways to say something or to use this type of words. It's from the PDF called Let's Talk Language of Health Equity. So yeah, I didn't know about this before I read this PDF, and we usually use this word vulnerable, marginalized, stakeholders was another word that I found in this paper. It was very interesting. So I'm going to share the PDF in the chat in a while. So yeah, I only wanted to make that comment.
Thank you. And that's a good point when you read papers from 2000, from 23 years ago. Sometimes the language is not used, you know, it's a different time. So good point. I don't know if we want to move on, or as we keep going, maybe feel free to use the chat if you have ideas about the who you might want to partner with for addressing improving oral health for people with disabilities, maybe based on who you've encountered and who might be relevant for that group. Feel free to keep writing, and we'll keep going.
Okay, so the next topic is determinants of health, and the first question is, What is the importance of addressing socio-political factors in oral health promotion programs?
Sure. So it's a heavy question, I think. But the way I think of it is that, social political factors, those are things that impact society or the communities that people live in. And those factors are, in a way, impacting how people make decisions about their lives or their ability to make decisions about their lives. So if you think that's kind of upstream, similar to what you've heard of upstream factors, I'm going to group them together. So if you have an oral health promotion program that addresses behavior, like please reduce your amount of smoking, please stop smoking, please, maybe you don't say please, but reduce the amount of sugar you consume, brush your teeth more, floss your teeth. You're requesting a person make that decision and implement that decision on their own without considering the environment that they live. So if someone's working 2 full-time jobs to pay their bills because they can't afford the rent, they're going to continue working, overwork and not have time to change their behavior or not think about changing their behavior because there's other things in their life that's impacting them. So if you go to the upstream level, you're helping change how they live and hopefully giving them a better ability to make those changes effectively. That's my way of answering it, but happy to add more comments or your thoughts as well. Maybe you had this encounter in the clinic and you noticed this person is never changing their flossing or something.
Sorry, Melissa. You go first.
No.
I talk a lot. Please go first.
Well, I have a little comment. And I have a patient that, he smoked a lot. And because also with the socio-political factors, I don't know if that, in that way, I don't know if that may be like a really important factor. But now that I treat that patient and he continue smoking, so I know that also the environment of the people and like as you told, I think about the environment could be also the education of the person. I don't know if that would be to know about the oral health or the health of their own person.
Yeah, that's a good point too. And it's a good reminder that sometimes when we think of the environment, like it doesn't have to directly connect to the oral health, like there's something with their oral health, like improving access to education. That's a win for us because then people are more educated, like you said. It's not going to be like a direct, you'll see it next week in the clinic, but over time you're improving the health of the population. And as dental professionals, you can advocate to make those changes. So you might not be directly involved, but you can be another voice to say this needs to be done because I want my patients to have good oral health or the community to have good oral health. It's a good point. Yeah.
I only wanted to say that addressing the political factors is very complicated, but it's despite of the fact that maybe we will not able to make a change, it's so important to at least know about politics or what is happening in our context and try to advocate for good things. Like we had a very horrible moment in Peru some month ago, and maybe we're still having this thing. But obviously, when people are living in these conditions, how they will be worried about their oral health, for example. That will be possible, like very complicated. So um, it's very important to be aware of all of this, of our context, and trying to identify why is this causing, or how this political or social political context is impacting our health, and why it's important to advocate for change. So yeah, I only wanted to make this comment, but it's important. Sometimes as a clinician or as a dentist, we don't like to talk about politics or about the things that are happening around us, but it's very important to do it because it is impacting our health.
That's it. Thank you for sharing that point too. And what I was thinking too, like sometimes we think of socio-political as like what's happening at the country level, and sometimes we should also think about it at like the local or city or town level too, and making an impact there is also I think a really good really beneficial, and like it's positive. Like we don't have to change the whole country, but maybe we can demonstrate how it can work in a local environment, and then other people are going to apply it in other contexts after thinking about a framework. But yeah, it's a good point.
Oh yeah, I never thought about it. So number 3 and the third question is why it is important to improve everyday living conditions such as education, housing, and urban infrastructure to reduce health inequalities.
I would say I would answer this similar to like the first two. Is just that improving how people live will hopefully give them more opportunity to think about their health and improve their health, and like give people an equal opportunity. Why do the rich have nice houses and they can buy homes, whereas people who aren't rich or have a lot of money, they have to be struggling every paycheck to afford their bills. So just something I think to re-emphasize that if we make improvements in the community, then hopefully it gives people better opportunities to make decisions about their behaviors or their health. Yeah, true.
Yeah, that's totally true. And the next topic is social inequalities and inequities. We have only one question, and it's how can preventive strategies be structured to avoid worse social inequities in health, and how this can be funded and sustained over the long term?
Yeah, this is a very good question. And okay, so how can preventive strategies be structured to avoid worsening inequalities in health? I think, so I'll start with the first part. How can they be structured to avoid worsening inequalities? I don't know if it's come up, but in terms of how they're planned, and at the planning stage to think about how it's evaluated, so that if it's not working, it can be changed or improved so that inequities are not worsening, like so that you're not making things worse. So instead of just implementing it's there, goodbye, thinking about how you can constantly monitor how things are improving. And that includes like collecting data and information That's how I would answer the first one. In terms of how can these be funded and sustained over the long term, that's a good question, because also in the health environment, people don't know, like if you look at primary care and physicians and doctors. But I think what some people are finding is, say you have a policy and you want to provide dental coverage for people. I'm going to use that as an example, a dental program. If it's a policy that's just, we want to do this, this is our guide because it's a policy, it's there for you, that's at risk of being removed because it's loose, it's informal. Say you have a change in government and they don't want to do it, it's going to be removed. So how it's, what I'd recommend, or what I think would be helpful, is having legislation, like law associated with an intervention, I think will help keep it sustained. Because once something is in law, at least in the Canadian context, it's difficult to remove it. So governments, even if they change political parties or something, they're still kind of bound to continue with a program. So that's one thing to consider. The other thing maybe to consider is the workforce who's involved in your policy or who's involved in your intervention. Do they actually like working in the program? So making sure people are happy, and oral health professionals or dentists, whoever's involved, actually are able to work to what they want to do, like their capacity and their enjoyment. So it's not a burden to them to be involved in the policy. So thinking about the end users there as well. But it's a really tricky question because it doesn't seem like there's a true answer, but just thinking about the legislation and the workforce involved and ensuring that it can be evaluated, and like it's flexible, you can make changes if needed. I think those would be important to consider. Whether they're all the things to consider, I don't know. But those would be my advice, maybe to think about. I've never read a paper that says this works and we're keeping it. So if I did, or if anyone has, please share it, and that would be great.
Lisa, would you like to share something? No?
No, not at all.
Well, I only wanted to share that regarding the first part of the question, that like we use in Peru, well, many parts of the world, I think, usually happens that people goes to a place and intervene and then forget about that. So it's very important, the planning, then the implementation, but then the evaluation of if this is working or not, because if not, we are creating more inequities. These campaigns that people used to do, going to one place with poor people, and then they have the picture of everybody and sharing social media, that is not helping. That only increases inequities. And it's, I don't know, it's only because of the picture and that's all. But that is something that most of the time we're not aware about it. So it's important to think about what will what will happen next after the implementation, and how can we will evaluate this. Only to say something apart, like in the last discussion forum, actually we will talk about the program planning and evaluation, so that will be a good forum to discuss about this part. But yeah, having a structure and also thinking about a framework, about those approaches that Julie mentioned before, the implementation science, the community-based participatory research approach, will be very important to consider while we are planning something. So yeah, actually the idea of these forums were also to share some ideas about these things, because also takes time to learn and to read a lot of things to understand it better. But at least now we know that doing only a campaign for one time doesn't work, like only increase inequities. So yeah, and regarding the second question, I think it also depends how is about the oral healthcare system of a place. So it's also important to know how our healthcare system works and to explore it at least. That is something that we are lacking to in Peru. Like, we have to explore it a little bit more, like write something. Maybe we could write a paper about describing our healthcare system that is a little bit complex, because it's very important to understand it before also we plan something and we promote something in our system in Peru. Dental care is funded by the government. Like, we have a universal health coverage, but I don't know. Well, it's not working because it's very saturated. Most of the people still go to the private sector to receive care, but we have dentists in the public sector who provides a lot of treatment. But yeah, how is this working? Also, it's important to evaluate why is this not working, or if it's working, how can we improve it? But yeah, I only wanted to share those thoughts.
Those are great points, and I hope you do write something about it.
Yeah.
And I was thinking, after you have these sessions, I think it would be great to is there promotion and prevention campaigns like in Peru? I wonder, maybe for some populations, but
Students, I think that I saw some undergraduate students doing some campaign, like health education, something like that.
yeah, they go into the school for one day, they
Yeah.
give toothbrushes, brush your teeth, and then they
Yeah,
leave.
and then yeah, but in Peru we do that a lot. As part of our courses of preventive dentistry, we do it a lot. And we used to think that that is the good way to do oral health promotion and prevention. But I just realized that that was the wrong way when I started a PhD and I started reading these papers. So yeah, but
do they? Oh,
yeah.
sorry. I
No,
was
no,
gonna
continue.
ask, do they have like a fluoride program in schools or daycares, or does public health, like the public dental system, do they go into schools, or are they involved in schools at all?
Some schools they are
Like
if
elementary, like grade 1, grade 2, or kindergarten?
I think that's some years ago in Peru, the government tried to introduce like a program called One Dentist per School. I'm not sure if that was the correct name, like in a way to have a dentist in each public school. But I'm not sure if they implemented. So they created like a regulation, but I'm not sure if they implemented, or not sure if they implemented in every school. I know that they implemented in some schools, but not sure how it's working now. So if anybody of you knows about that, please let
I
us
think
know.
Abby says it was in somewhere, but it doesn't exist anymore.
I think so.
The limited Spanish I know.
Abigail said that, yeah, they implemented in one region that is called Junin, but it doesn't exist anymore. Yeah. Yeah, I think that this strategy started in Junin, in this region which is located in the highlands, but then I don't know what happens, maybe. But we have in all the primary care services, we have a dentist who provide these services. Actually, the dentist who works in the primary care, they have to go to the schools to do, well, they usually do health education. I'm not sure if they provide fluoride varnish, but the most common strategy is health education. And maybe we could, if we have time, we could talk a little bit about how health education also can increase in English. But,
Yeah.
but yeah, um, we have another comment in the chat because
Somebody wanted to do it, but somebody didn't. I don't know.
yeah. Well, Carla said that they tried to implement it again because, well, I think we have. I'm not sure if we actually have a person who is from the college, dentistry college, the Peruvian dentistry college, who is currently also in the parliament, like the Congress. So maybe this person is trying to advocate for this program in the parliament. But yeah, here, every law has to be approved in the parliament. The parliament has like, I'm not, please correct me if I am wrong, people who are here. In the parliament we have like more than 50 people. Like, I'm sorry, I feel so bad. But I don't remember. We have a lot of people from different parties. They have to agree in a law, and sometimes there are a lot of conflicts because they interest with their parties, as happen in many parts of the world. But yeah, the Peruvian parliament has a very bad reputation. But yeah, I don't think we have one person who is a dentist, who is advocating for this at the school, in the school. But I think that this program has to be very carefully planned and organized to know also how it will be evaluated over time. Because what I understand is that they only said, yeah, let's have a dentist per school, and then what this dentist will do, how we will do a surveillance, how we will know if it's working, how much it will cost. So it's also important to do a very good plan of this to convince the other parliament. So yeah, that is what it is.
I think in Canada, one of the things that like an interest group did, like a group of dental professionals, is they made kind of like a white paper or a guideline of, we think this would be good for improving health. And it was like not too detailed, but it gave like the fundamental, like, these are the core things that should be implemented, and this is why, and here's the evidence. And like a lot of professional associations do that too, like the Dental Association in Canada, they'll meet with members of parliament and they'll talk to them, and they'll advocate for themselves. But it's one way to, you might not be advocating for dental care, but maybe you say housing is important and we want you to address that. We're another voice, you should do it this way. Like, I don't know, I'm trying to bring in some of the things we talked about, but it's one way to hopefully get something effective in your schools. We have screenings and fluoride varnish. So screen for caries and then refer to dentists or in the public or private sector in Canada. And that, I think, is something, I don't know if you have screenings or it's just the dentist is there hanging out in the hallway in the school.
Do you mean in Peru?
Yeah, in Peru. But it seems like there are no dentists in the school right now, but it was the idea. Okay.
They are in the primary health care service, and they have to go to the schools in the neighborhood of the primary care. But not sure if maybe it depends a lot about on the dentist who is working in this primary healthcare service, because they usually only do oral health education and provide toothbrushes and toothpaste to the children. And they only go to the, I think that they only go to the public school. So to private schools, it's no, they don't. So in Canada, what I understood is that this program is happening in public and private. So it's like a population approach intervention, something like that.
I would say,
Sorry.
you know, we should have like a fireside chat. What happens in Peru? What happens in Canada? And it's good to learn how different systems work. So I like this conversation. It's only public schools, but it's the whole population of, you know, kindergarten students in public schools. So technically it's a population approach because it's all those children, but it's not the whole population of children in our country or in our state or province. So yeah, population.
Yes. Most of the schools are public here, right?
Yeah, but there are you have to pay a lot of money for private schools, like prestige private schools. I think Melissa, you had a comment or your hand.
Oh yeah. Well, for example, as I heard, oral health education, it's like the bad way to prevent. No, so how can, for example, students of the first year of dentistry could prevent or could go to the schools, to the primary schools, and do like preventive strategies, a part of oral health education or a guidelines, as I heard too.
Yeah. What I would say about education, like it's not all negative in terms of like don't do it at all. It's just that it's not going to improve the oral health of everyone. It might create inequalities because some people have more resources and access to make those changes than other people. So so it's like the inequality will probably still exist, but some, you know, more people in the higher income group will have an advantage. So it's like slowly improve. Not everyone gets the same benefit. So it's still a good thing to do, but when you're thinking of interventions, you have to pay. Yeah. Okay. Thank you, Beatrice, for that. Is good to know. When you're thinking about interventions, you're spending money on it. So what would be most cost effective, like the most bang for your buck, or, you know, the best outcome based on what you're spending? With well, would dental students do these things for free, I guess?
Yeah. We do in school.
In school.
Yeah.
So I mean, I guess a good thing is that you're already connected to schools. So maybe what else could they do in the schools that might be beneficial? And I'm seeing the fluoridation. Would that be the fluoride varnish, you think? I think continuing engagement, like maybe monthly visiting schools, maybe doing screenings. So referring, you know, identifying people who need treatment and referring, that could be something that's beneficial. But having that point of contact connection, I think, is good. Education is, you know, it's good to be there. It's just what else would be better? But since nobody's paying for it, I guess it's okay because it's free. But I guess in the mindset of if you're paying for something, what's better, education or fluoride varnish or screening or a dental sealant program? That's when I would say education is not the best. I don't know, Camille, if anyone has thoughts on that?
Yeah, apart from that, doing oral health education, you spend a lot of resources and time. I remember I really enjoy it in my undergraduate. I use like costumes like of a teeth and a monster. We created songs. We tried to do it very good health education, but it was very exhausted. And it's like when we I remember that we did a lot of this in rural communities, and you spend a lot of time doing your theater of the teeth and the bacteria, and also we were thinking still on the bacteria and not the sugar. And also, and then a few minutes before of that, we're still looking at the children with the candies are, so it was a little bit frustrated. We spent a lot of resources and time by doing that, when maybe by doing screenings and referrals and fluoride varnish will be more effective, more cost effective. Like
You have to tell us with your thesis.
yeah, yeah. So and you, as you said, also in terms of the inequities, yeah, not everybody could have the opportunity to go for the dentist, or maybe because it's so far, or I don't know, they don't trust in the dentist of the primary healthcare service, or they don't have money to afford a private dentist, or I don't know. There are many things related to barriers to healthcare access, but um, so if you say to the people, the population, you have to go to the dentist every 6 months, you have to buy a very good toothbrush, and maybe they will not afford for that, and yeah, and then you are creating these inequities.
I like these questions. I feel like you should have a session on like brainstorming.
What should we
It would be
do?
very good. Yeah. Or just here's a population, here's our situation. What are some ideas of how we can improve it? It's good. It's good to have solutions.
Yeah, yeah. So, and involving the community, like
Yeah.
in these meetings also, if someday we have something like that in some community, we have to work with the community, because we could think, yes, this, we have a very good idea, this will work super well, but then the community has a different belief, and I don't know, culture, different reality, so our
Yeah.
best intervention will not work. So
Yeah. It's a good point. But I would say as this evolves, maybe different people who are on the call, they can share, here's what's happening in my community.
yeah,
I want your advice, and how
totally.
can I bring this back to my community? Everybody loves, or here's what didn't work. I think the best is when people talk about what didn't work, and how you can learn from mistakes or things that didn't work out, how to hopefully avoid it. I think that's a valuable. Anyway, keep talking. I had too much tea.
So okay, let's move on. I think that this was the last question. So
Yeah. Well, thank you, Dr. Julie, for answering all the questions, and well, also thank you for your time to be here. And well, now, we provide us some key messages, like as a summary of the forum, please.
Sure. And it was a pleasure to be part of the forum and to answer these questions or talk about these questions. I think there are many ways we could have went, but I'm happy that we had the conversations that we had. So I guess going back to the readings that we had and some of the conversations that we had, one of the first key messages is that common risk factor approach. So just reminding us all that many diseases share the same risk factors, and it's important for us as oral health professionals to consider how we can collaborate with others to reduce these risk factors, to optimize, oral health and prevent disease. The other kind of key message I would think is the issue of who you're targeting with certain interventions. So interventions that target the context in which people live their day-to-day life. So thinking about housing, affordability, or stress, things that impact stress, those might be more effective at reducing inequalities and improving oral health. In terms of what populations we're addressing, I think we talked about how the targeted group approach means that people have to make decisions about who's going to be targeted, and there may be risks because you're missing certain at-risk groups. There may be risks because that program or policy might have a negative perception of it because of affordability and people can't afford care, or there may be risks because it limits coverage and limits what people have options available to. But that a targeted group is beneficial because you are identifying someone who would benefit, and hopefully you're reducing their risk of disease and improving their oral health. And I'll just do a last one because I think I'm talking too much, but the other one to consider is how the universal approach ensures that everyone benefits, but may have some people benefit more than others. So it might not reduce inequalities. And I think as we were talking, just to consider whenever you're planning these interventions, which I think is going to be a discussion in a later forum, is to consider the community and involve the community that you're planning that intervention about. So those are my points. Oh, thank you for the applause.
Thank you. Thank you. So now we pass to Dr. Camila.
Well, I would like to thank you, Julie. In name of all the group, we are very grateful with you for your time, for sharing your thoughts in this forum. So we would like to give you a certificate for your outstanding contribution as an expert in our dental public health study group, Qhali Peru. Your dedication and experience have been fundamental for the growth and learning of our members about dental public health, and we sincerely appreciate your commitment and unconditional support, and we hope to continue counting on your valuable collaboration in the future. So thank you so much, Julie.
Thank you. It's been a pleasure. Thank you.
Okay, so before we finish, only I would like to remind everybody to complete this survey to know how this forum was, and if you have any other comment or question, please share it on this survey, and then I can provide it to Julie. So Melissa, can you also share the link on the chat? So you have this QR code, but Melissa also is sharing the link, and I think, and then I only wanted to announce the next discussion forum that will be in 2 weeks, at 30th of September at 8 p.m. Peru time. And we will have Faraz Moharami in this forum, and we will talk about assessing risk for oral diseases at an individual and population level. So I'm going to stop sharing my screen to only have the opportunity to see all of you. So please turn on your cameras to have our picture. Yes, thank you, Jessica, for reminding me about the picture. Yeah. So I'm going to close it. Okay, please turn on your cameras. Don't be shy.
I was going to say you can use the filter, maybe put a mustache or a hat.
It's nice to see you. It's nice to see everybody. Hey, hello. Okay. Yuli, have you noticed that most of us are girls?
I feel like I'm looking at a group of twins or triplets or everybody. We're all brunette, I think, so far.
Okay, so Jessica, can you take the picture?
Yes, Gabby. Hello.
Jessica is the director of communications. She's who do the beautiful flyers and posts for our social medias. Okay,
Okay,
let us know.
we are going to count to three to take the picture. Okay, 1, 2, 3. Yes, up the picture.
Yay.
So maybe we can say hello for
Like this? For the
okay,
picture or like a recording?
yes, a recording.
A recording, okay. Hey.
1, 2, 3.
It's okay.
Uh-huh.
Okay. Okay, so thank you everybody for joining us on Saturday night. Maybe some of you have something else to do after this format. Thank you everybody. Thank you so much, Julie, for your time. Thank you, Melissa, for organizing the forum too. I don't know if would you like to say something else before we close the Zoom?
I just realized there's some of you still in clinic. I love it.
Maybe. Yeah, I told
Maybe.
Yuli that many people worked until very late on Saturday. And
I
she
thought
told
the
me,
clinics turn into bars in Peru because it's late on a Saturday, but that's okay. I hope you all have a nice weekend, and I hope to see you again or talk to you all again
Yeah.
at some point. So it
We
was
would
nice
love
to
it.
see your
Yeah.
faces and your comments. Okay.
Bye. Take care, everybody.
Bye, thank
Have a
you.
nice weekend. Bye.